Welcome to Eye Contact. I'm Nic Reus. Today we are talking to Professor Dr. Rudy Nuijts about phakic IOLs. Welcome, Dr. Nuijts.
Thank you very much, Nick.
How do phakic IOLs fit into the menu of refractive vision correction options now available to patients?
Well, I think that over the years, phakic IOLs have found their own place in the treatment of at least high myopia. As you probably know, in my country, in the Netherlands actually, which is also your country, of course, we have defined inclusion criteria for using phakic IOLs. And we think that above a level of -8 diopters, the results with implantation of a phakic IOL is actually better than let's say, corneal refractive surgery. And that is related also to the optical quality that people can get, so the quality of vision after implantation of a lens versus a correction on the corneal surface. So that's one of the indications. The other indications, of course, is in those cases where you don't actually trust the cornea. So in those cases where you probably might think it is too thin or the shape is a little bit different, and I'm not very confident that corneal laser surgery would have a very good effect, or probably would have some more problems with the incidence of complications. So two groups actually, I think, based on the refractive error and also based on the shape of the cornea, which are the indications primarily for these kind of lenses. And then, of course, you have to check whether the patient fulfills the criteria. And that depends on the morphometry of the eye, especially also when you are looking through the lenses in the anterior chamber. So we only have now actually two, as you know, so iris fixated IOLs and lenses that are placed in the posterior chamber. And there are really very strictly defined criteria for that. So for an iris fixated lens, as you probably know, the distance in the anterior chamber is a very important parameter. So it has to be at least 2.8 millimeters between the anterior pole of the lens and the endothelium, to name one. And we also, at least in my department, look at the distance of the edge of the lens, iris fixated lens, towards the endothelium, which at least has to be 1.5 millimeter. So that, in terms of morphometry, is one of the main issues for us when choosing a phakic IOL in the anterior chamber. And that is the lens actually that I have the experience with. So I don't have an experience personally with placing lenses in the posterior chamber.
And most viewers probably know this, but why would you need that distance to the endothelium?
Because we know from our research and also from other people that there is certainly a relationship between the distance and the likelihood of endothelial cell loss. So the closer the lens is to the endothelium in the center, but certainly also in the periphery, the higher the endothelial cell loss might be. Just as there are other risk factors. So we also know, for instance, that people who rub their eye are not very good candidates. So you have to be aware of them, and you have to actually warn people also that they shouldn't do that, because that's a risk factor for increased cell loss.
Okay. And surgeons have long debated the relative merits of anterior chamber phakic IOLs, such as the Off-Tech Artisan lens, versus posterior chamber phakic IOLs, such as the Star ICL, which you just mentioned. What do you think we are in that debate today?
Well, you know, it's an interesting ongoing debate for many years already. And the debate is a little bit foggy. And what do I mean by that? I mean, from a scientific standpoint, it's foggy. Because the groups are different. And what I mean by that is that we have seen many design changes in the ICL over all the years. So you're always coming new lenses with limited follow-up and so on and so on, while the Artisan or the Artiflex lens actually hasn't changed significantly during the last 15 years actually, and the Artiflex since its conception in, what was it, 2003, I think. So so the design for the posterior lens is different versus this design is the same. Let's say the gold standard for comparison of these lenses has never been performed, which is there is no randomized clinical trial comparing these two lenses in the literature. It's not available. So what we can do then is second best in terms of science is looking at long-term cohort studies. Now we have done a long-term cohort study with our Artisan and Artiflex group and looked to that over the years. So we have now 10-year data for the Artisan lens, which is quite special, I would say. And what we came up with there is that in terms of refractive and visual outcome, you see some changes over the years in the sense that the percent of eyes that are within 1 diopter and half a diopter tends to decrease, the uncorrected vision tends to decrease a little bit, and that's related to actually the fact that the eye still grows a little bit over the years. We measure that with biometry, and probably also because the lens changes, of course. The lens becomes thicker, and it has an effect also on the refractive outcome. So those are the changes that we see in terms of refractive and visual outcome. But one of the most important questions, of course, is what is the effect on the endothelial cell loss? And what we saw there is that, roughly summarizing, is that in a 10 years time period, the annualized cell loss with lenses in anterior chamber, eyes fixated, is roughly 2 to 2.5 times what we see physiologically.
Okay.
So physiologically, it's around 0.6%, and we see around 1.2 to 1.5% per year over that 10-year time period. Okay. So definitely there is an increased cell loss. Does that lead to explantation? Yes, it does lead to explantation in some of these lenses, and at the 10-year time point, exactly, the explantation rate because of endothelial cell loss reasons, and we apply the criteria that if the lens has more than, if the patient has more than 30% loss or the density is under 1500, then we explant. So in our cohort, 1% of the, let's say, myopic lenses, 4% of the myopic toric lenses were explanted. Okay. So that's a figure that you have to take into consideration. The other question then, of course, is, that what about posterior chamber lenses and ICL? Because, well, there are many people who claim that there is no cell loss with these lenses. I think that there is limited data, long-term data for ICL, as I told you before in the literature. But if you look at the data that's out there, that is good data. So the FDA study in the past and some studies that use reading centers. Actually, in those particular studies, which was an older type than what they use now, the annualized cell loss was also 2 times. 2.5 times. This was comparable. Now, 10-year data for the ICL are not very frequently seen in the literature. There are a couple of series. There's one series, think of Moya, that shows about a 19.8% cell loss in a 10-year or 12-year time period, which is also higher than what we physiologically see. Question is, if the new lens, of course, with the hole in the center, with the aquaport, if this lens is going to change that. I don't know. There's only one study now of Shimizu, who has compared this aquaport in one eye with the conventional one in the other eye, and he shows after 5 years 0.5% loss, which is, I think, difficult to understand because the physiological loss is 0.6% per year. Yes. So I think we really need more long-term data to give an accurate answer to that. What we do know from the past, though, is that the other complication with the ICL, which is, of course, the formation of cataract, anterior subcapsular cataract, can be around varying from 10 to actually 18, 19% if you look at the long term. And some of these eyes will need cataract surgery, which will lead then in these highly myopic eyes to an increased risk for retinal detachment, I think. So you have to balance different complications between the two groups of types of lenses, actually. Yes.
And it sometimes appears that phakic IOLs are gaining ground over anterior chamber IOLs, the artisan lenses. What do you think reasons for that might be?
Well, there are certain advantages of using the small incision ICL. For instance, when the refractive error is above minus 14.5 or minus 14.5, you cannot use the Artiflex lens. Okay, so you have to switch to the artisan, which is available in 5 or 6 millimeters, so you have to make a larger incision as compared to the ICL. This will transfer, of course, to a lower, let's say, efficacy, I think, because these lenses have more induced astigmatism, a little bit more, and the uncorrected vision may probably be a little bit lower as compared to the ICL. That's what you can see in the literature. So that there is a difference. The other difference actually is in the future, because we know that all these lenses once need to be explanted. if you need to explant the artisan lens, my preferable technique is to make 2 separate incisions. One to remove the lens, temporal incision to do the phaco, because the chamber is more stable if you do it from the temporal side. That problem is probably less with the ICL, because you could do the same smaller incision where you take the lens out and so on. So that's a practical advantage. Are there other reasons why they are gaining ground? Well, I think that some people believe indeed that they have less endothelial cell loss, a factor, as once again, where I don't see enough evidence in the literature that is really true. But it's my impression, talking with people, yes, that ICL become more popular. I cannot give you the data from the manufacturers because they don't share the market data. So the actual figures I cannot provide to you. But this is actually from what I know, what I hear.
Yes, and you said that you personally in your institution you use the artisan Phakic IOL. Would you consider switching in the future to the implantable Collamer lens, the ICL?
The point is, I would be happy to switch if I knew or would see the data from a very respected center that could give me their, at least 5 or preferably 10-year follow-up, because we know that what you see in the eye in terms of endothelial cell loss with Phakic IOLs is only going to appear after 10 years. Studies that have a shorter follow-up won't show you a lot, but if you go through the 10-year time period, then you will see really the changes, either in cataract formation, endothelial cell loss, explantation rates. And that's something that we have learned. That's a lesson from the past, actually, when we had the rigid angle-supported lenses, where it also took 9 to 10 years before we got into really trouble.
Yeah. Well, thank you very much.
You're welcome.
Rudy. And for more information on this and related topics, please visit us at eurotimes.org.